Right, hello everyone. Just sent a request for Dr Amanda Selk to join us. Wait for more of you to join. Right, I sent a request, hopefully that'll work through. Today we're talking about lichen sclerosus mainly. If we get a chance, we talk about other vulvar conditions as well. But as it's going to be World Lichen Sclerosus Day on Tuesday, we're going to concentrate more on lichen sclerosus. Right, I've sent a request, it's not letting me send another one, so let's cancel and then we'll try again. Right, I sent invite.
There you go.
Aha, done it. That was easier than I thought you would be.
Hey.
Good morning.
Good morning.
Thank you for joining us. We'll let everyone know who's who because many people hopefully will share this. So I'm Clare Baumhauer. I started Vulvar Cancer UK awareness 6 years ago after being diagnosed myself, and work with Emma Norman, and we have the website and awareness pages. And I first came across Dr Amanda Selk on Twitter a few years ago, and I asked her if she would do a live with us to help explain more about lichen sclerosus, and fantastically she agreed. So I was misdiagnosed for 38 years. I probably had lichen sclerosus from the age of about 5. I went to the doctors many times, but I was told it was cystitis, thrush, herpes, even vaginal atrophy. So eventually I was diagnosed, but at that stage it unfortunately turned to cancer, stage 3. Because obviously I was quite angry with getting misdiagnosed and saw the lack of awareness and training. So that is why I sort of started all the things that I do. So that's me. So Dr. Selk, would you like to tell everyone about you and your background?
Sure. So I'm an obstetrician gynecologist in Toronto, Canada. After my obstetrics and gynecology rotation, I spent a year doing extra dermatology training with one of the, rare people who did a lot of vulvar disease, because many of you may see that it's hard to find someone knowledgeable in this area. So I just happened to work with somebody who did a little bit of vulva and then realized, I kind of like this, have eyes for small details. So then I spent a year with someone who knew a lot, and we did clinic together for 4 years. And then I got very involved in teaching and research, and here I am. Now I'm president of the North American Society for the Study of Vulvovaginal Disease, and I have a big practice taking care of people with conditions like lichen sclerosus.
Brilliant. Right, so now we both know who's who. I'll start off really just by, if you can explain to everyone that sees this video and knows nothing about lichen sclerosus, who gets it, what it is, and what we know about it.
So lichen sclerosus is felt to be an autoimmune skin condition. So autoimmune meaning that your body recognizes normal tissue as abnormal and starts to attack it. Okay, we don't really understand why people get autoimmune conditions, but people who have some are more likely to have others. There is a genetic component to it. So if you have it, there's about a 15% chance that somebody else in your family has it. But I always joke that it's not classic in our conversation. So most people don't know that someone else has it. But if you do have it, it's worth having that conversation. It is a chronic condition, meaning that it lasts forever, as far as we know. We don't have a cure to it. Again, it's a skin condition that tends to like the genital area. It can happen to people of any age. So in textbooks, it will say that this is a disease of postmenopausal women, mostly. I don't think that's true. I think it can happen really any age, but there may be some extra diagnoses after menopause, as for some people there's an estrogen component, but we see it in children, we see it in reproductive aged women, we see it basically anytime, but it might present a little bit differently in different ages.
Mm-hmm. And also, if you can run through the symptoms, because obviously we don't, oh, that's my cat. Obviously there's a lot of symptoms, and you don't have to have all the symptoms, and I think that's where a lot of, I think, GPs get misdiagnosis, because they assume that we're all going to have white patches. So if you could just go through all the symptoms that lichen sclerosus can give us.
So in medicine, we think of symptoms as things patients tell us, and signs. The word signs is things we can see. So just if you're reading, to know the medical differences between the two words. So symptoms would be most commonly things like itch. The word irritation, although there's not a good definition of that word, but when I've done studies and asked people what bothers you, number 2 is always irritation. So that word. Pain with sex, dryness, tearing, feeling like little cuts in your skin. If you look, you can see sometimes white patches, sometimes what looks like bruising. You can see anatomical changes like scarring and fusion, and sometimes loss of structures. Those would be some people have trouble with when they're constipated, they get little tears around their anus. That's another one. Those are all sort of, I would say the most common initially is itch, but that tearing with sex is very common in younger people. And then there's a big group of people that have no symptoms, and that's a problem. That makes it hard for us to know exactly how common it is, because, you know, you can walk around and have you feel completely fine, and then somebody looks at you and says, actually, you don't look the way you should, because there's whiteness or scarring. And so people don't always look, so they don't always know that there's changes.
That's the important part, isn't it? It was, you know, I never really looked much. I wish I did, because then I knew what I looked like before. You said about constipation. That's quite common in children, isn't it? Do we know why it's like that? I
don't know. You know, kids are, I think kids are interesting, because I don't see, personally, I don't take care of a lot of children, but it is true that in kids, one of the top presenting things is like tears perianally. So the other thing with that is that, like, I mean, children are often constipated, but then you wonder if with the lichen sclerosus piece is when you have disease around your anus and the skin is tearing, little kids are probably more likely to hold it. So, and then that maybe that the constipation is sort of as a result of the tearing, as opposed to constipation leading to tearing. And then it would be a cycle, because it's harder, it'll tear more. Yeah. And that can happen too, I would think.
Yeah, because that's one of the questions my dermatologist asked me when I was finally diagnosed. Did I have constipation as a child? Quite a lot, which I did. Also, talk about the areas where you can get lichen sclerosus. The figure of 8 is mentioned quite a lot, and also we can get it obviously in the anal area. If you can talk a bit more about that.
So to understand the term figure of 8, you need to know a little bit about your anatomy. So you think about the vulva is at the top, so the labia, the big lips and the small lips, that's the upper part of the 8, and then down around the penis would be a bottom part of an 8. So that's what people talk about as a figure of 8. Again, that is advanced disease textbook, okay? Like, again, clinicians who don't know a lot about lichen sclerosus, many of them, by the time you get disease everywhere, and it's in that figure of 8, like you can see it both top and bottom, then everybody, usually not everybody, people will start recognizing it and say, oh, this doesn't look, but it didn't start like that. So it can start anywhere. You can have disease only on your clitoris. You can have disease only on your small lips. You can have disease only on the perineum, which is the spot between the vagina and anus, that flat area. You can have just perianal disease. So again, it can be in any of those places, and it can be a little bit white, you know, just a little bit shiny. It doesn't have to be this dramatic change. But again, I said it's a chronic progressive condition. So if you don't treat it, it will slowly get worse. Some people quickly, but most people slowly over time will increase, and I hope that through things like this, as people get to know, and they get earlier diagnoses, we can stop it before it gets to the whole figure of 8 scenario.
Also, a lot of people aren't sure that whether lichen sclerosus affects the groin or not. Is that a common place or uncommon place?
You can see it sometimes. You have to be careful there because there's another condition called psoriasis, which inverse psoriasis often affects the groin. And I mean, you can also have both because again, you don't have only one thing. It's easy to say it's just one, but sometimes the conditions get misdiagnosed. Sometimes you have more than one thing. Sometimes people yeast or thrush in the groin is a common place. So again, you can have more than one. And sometimes it is lichen sclerosus in the groin, but I'd say that that's less common. Extragenital, meaning outside of the genital area, lichen sclerosus occurs in up to 15% of women. It likes to be under the breasts. But again, I've seen it arms, legs, everywhere. Again, little shiny patches looking kind of like cellophane, saran wrap. I don't know what you guys call it. The plastic wrap is shiny.
Yeah, same thing. Also, it doesn't affect the vagina either, which a lot of people get confused with. Obviously, knowing the difference between the vulva and the vagina helps, which I will add the leaflets and pictures as well after I've posted this, so people can look at whereabouts every part of the body is. But so it doesn't affect lichen sclerosus, doesn't affect inside, as in the vagina.
Right. So if you're having problems inside the vagina, the two things that are very important is this: if you're menopausal, right, then menopause affects the vagina. Once you go to menopause, the vagina becomes thinner, less stretchy, less moisturized, less lubrication. So some of it can be menopause, but there's a different lichen called lichen planus that likes the vagina. And some of the findings in the vulva, both the symptoms and what it looks like, can be similar, and you can have them both.
Yeah, we'll talk more about that later because there's so many. I didn't realise until doing the awareness how many conditions there are that affect both the vagina and the vulva. So we'll talk more about them hopefully towards the end. Next part really is about, we'll go on about treatments as in the steroid, but a lot of people aren't really understand the difference between what fusing is, what scarring is, what architecture loss is. So if you can just explain a little bit about what LS can do to what it looks like.
Yeah, and I think this is such an important education piece about learning what your body's supposed to look like, or what we all look different, right? We all have different hair color, we all have different vulvas. But in general, you're born with a clitoris, which is a little bump at the top with lots of nerve endings, and it's like free and open. And then you have 2 big lips, and these change over your lifetime a little bit in how, from when you're a kid to when you're an adult, they change with the hormonal changes, so they get bigger. And then you have those with the little lips, and little lips can be from small to very big. They can be both like sit inside the big lips or outside the big lips, and both of those are completely normal. And so that's sort of your basics, what you're supposed to have. And what can happen with lichen sclerosus is you can get fusion, so where the skin sticks together and covers over the clitoris so you can't see it. The small lips, the labia minora, can either stick sometimes outward to the labia majora, like they stick together, or they can flatten and they disappear. So if you see somebody who doesn't have them, I've never heard of being born without them. And so some kind of inflammatory thing has happened because they've disappeared. And sometimes they actually stick inward. And I've seen people come in where it's so dramatic that they're leaning forward to pee because they can't, because the opening's like 2 millimeters and they have to lean forward, or it's fused at the bottom too. So like that opening to your vagina has really narrowed. And again, this did not happen overnight. This happened slowly over time in untreated, undiagnosed people.
So we'll come to using steroids, hopefully at this stage you've been diagnosed, been given steroids. The biggest question we probably get asked is, once you start using the correct steroids in the correct way, we'll talk about that again after, can steroids stop any fusion, and can it reverse any changes?
So generally speaking, they can't reverse things that have already happened. They can reverse color changes. So the whitening and the bruising, that can be reversed. So color changes can be reversed, but they can take quite a while to come back to normal. But structural changes, so the fusion or the loss of labia minora, cannot be changed with steroids. So I usually say we're trying to keep what anatomy you have now and keep it there from progressing in the future. The only study I've really seen about steroids preventing change is a study from Australia where they followed 507 women over time, and the vast majority of progression, so more scarring, were on people who were not using their steroids either at all or the way that the physician had asked them to use it, which was generally a strong steroid twice a week forever. In the patients that were using their steroid appropriately, 3% still progressed, but that means 97% didn't. So the vast can't stop the change for everybody, but we can stop them in most people.
Yeah, that's good. Yeah, because I obviously had lichen sclerosus untreated for 38 years, so I probably could tick every single box that the symptoms of LS have. My skin was white and silvery, and as soon as I started the steroid, which my oncologist gave me, before they'd done the surgery for the cancer removal, he gave me the steroid anyway to use, and I think it actually turned, because I think I saw him 2 or 3 weeks later after using it daily, and obviously I didn't know what it really looked like before and after, and I didn't really look at that stage, didn't want to, but because I just thought that colour was normal. He was so shocked on how in that 2 or 3 weeks that most of it had gone back pink again. So I do know for a lot of us it can obviously go from white to pink, but not necessarily everyone, but like you say, it can take a long time. And I think that's the main problem with a lot of us, probably any condition. We want an overnight fix. We want to see things happen quickly, and sometimes we don't, and that stops us from doing it properly because we think, oh, it's not working, I won't use it anymore. So that's one of the main problems. I think people want things to happen too quickly, and we are all different, so it can take some longer than others.
I think the itch, if it's itch that's your symptom, again, not everybody, but for most people, steroids really help itch right away. And so, and people, they think they're better, and they're not. And so, like, you're feeling better, but your disease is not gone, my friends. And it doesn't mean that it's not causing trouble. And so as soon as people itch, and it's totally normal, right? You feel good. No one wants to take drugs forever. Like, who does? Right? No, every disease, like we don't want to have chronic diseases, right? Like nobody's happy about their diabetes or their high blood pressure, but you can feel fine and you can still get sick. And so this is the same. You can feel fine and you can still get worse. So it's about also sticking with it and trying. Some people get reminded, right? As soon as they stop, they get and they're like, oh, I should use it. But other people feel good, they think they're better, and then they stop using or use less. And I find that they get into more trouble. And
so let's talk about treatment, which is we'll talk about the steroids first. So if you can tell us what steroids, why we use them, and how often we use them. So
steroids, okay, the word scares people, okay, and I don't really understand why, but I know there is. I get people will say, well, because there's all these side effects, but a lot of the problems with steroids are related to systemic oral steroids. Like when you're taking big doses of injectable and oral steroids, yes, there's lots of side effects. Topical steroids have some, 100%, but the vulva as a part of the body, if you use the right amount in the right place, it's actually quite uncommon to get side effects. And both your physicians, your pharmacists, everybody's trained that, oh, be careful, be careful, be careful. But as someone who does this all day, every day, we have far more trouble with people not using them enough than people using too much. And if you're watched carefully, you don't usually get into trouble. So I want to start with that because I think it's very, very important to know that taking care of this disease is extremely important. And if you've got any side effect, like a bit of irritation or even a bit of thinning, which is rare, very rare, like at most probably 1% of people get thinning. Lichen sclerosus is a disease that thins the skin. That's what it does. Okay, so a lot of the time people think the steroid is thinning their skin, but it's actually they're not using it or not using enough, and the disease is getting worse. So it's the disease, not the steroid. Okay, so again, signs of too much steroid are more things like you're getting red, bright red, and that's a sign to back off a little bit about how often or how much. Okay, so that's as a little bit of background. So steroids come in huge numbers. Like technically in medicine, there's 7 classes of steroids from super weak to super strong. And an easy way to remember is hydrocortisone, which in many countries is something you can buy without a prescription in the pharmacy, is the weakest thing. That's why you can buy it that way. It's not enough for lichen sclerosus, okay? So if anyone's telling you to use that, it's probably not the right thing. Clobetasol is in the strongest category, up on the other side. And my joke is physicians only know the 2. And dermatologists know them all, but everybody else learns those 2, and they don't know that there's stuff in between. So they're like, oh, one doesn't work, we'll try the other. And it's kind of ridiculous because they're on opposite extremes, okay? So starting with, there's in medicine, the best trials are called randomized controlled trials. They're like the biggest evidence. We have randomized controlled trials for the treatment of lichen sclerosus, and they say that you should use clobetasol, okay, as the first thing you try. It's, you know, I guess the trial usually been comparing clobetasol to other things, but at the moment, that's what we have the best data for. So you use clobetasol, and so usually it's this is slightly nuanced between people, but say on average, people use it twice a day for a month, once a day for a month, every other day for a month. Sometimes it's once a day for a month, every other day for a month, twice a week, you know, but generally.
I think that's the main problem, because we're getting told by different doctors so many different ways to use it. It does get a bit confusing, because most of them are saying once a day and every day for a month, and then every other day for a month, yeah. Like the British Socialist.
I think that's a bit of a US UK difference. Like I feel in the US they're a little bit like twice a day. There's a pharmacy study, the trial absorb is probably the same, so you don't need to use it twice a day. I think I don't use twice a day very often unless people are super thick skin, like it looks really bad. So that's the other part, right? You're all different. So again, there's if you don't know much, you have a recipe that you use for everybody. And if you're seeing somebody who sees a lot, they might tweak a little bit because you don't look as bad as other people, or you look a lot worse. So they might be a bit more aggressive if you're worse. And if it looks really mild, they might not quite treat you as aggressively as you've read, right? So that's something to think about. And it doesn't mean they're wrong, right? You can ask questions like, why is it I read? Say, because you don't look so bad, because we're catching you early, right? So did you partially for whatever it is. But again, most of the time, the principle is kind of hard to control it, and then try to keep it quiet with whatever you need to keep it quiet. And for most people, that's twice a week of a strong steroid, but sometimes people need 3, sometimes people need 1, sometimes people need to be dropped down to middle, because then they can use it more often. And it's really hard to remember something once or twice or 3 times a week. So if you can use something that's like weaker, but you can use that, say, 5 days a week, take the weekend off, it might be easier to get you to remember to use it. And when you can remember, you're more likely to stay on.
Yeah, that's true. So we know that ointment is better than cream as well, isn't it, when it comes to steroids?
So creams are white. Again, how do you know what you have? Creams are white, and ointments are clear. So they're clear. They're more in a Vaseline-like base. So they're stickier. So we like, in general in vulva, we like that ointment based because it tends to stick a bit better, although really you should be rubbing it into your skin. And if it's really rubbed in, how sticky is it? But you want to rub it in. The other, that if you have lichen sclerosus where you have little tears in your skin, then they're like open cuts, right? You know, when you're peeing, they're burning, they kill. So if you put a cream on that, it tends to burn, right? Because creams have alcohol in them. So, and you think that you're allergic to the drug and you're not. It's the cream irritating the cuts. So the ointments feel better. And again, we're trying to get people to use the things we want them to use and stay on them. Like, you got to work with everybody, right? So that's why vulva doctors like ointments. That being said, sometimes you have a patient who's like, I really like the creams better. They work better for me. That's what I use it. Then go with that, right?
Yeah. The other thing as well is how much to use, because we're told as well, again, I've always said it depends on how bad your LS is and over what area it is, but we're told a pea size, we're told half a fingertip size and a fingertip size. So when would you use what amount?
So, I used to, I think that's hard. So because, we used to look at meetings too, right? Like, oh, peas, they're all different sizes. But then I thought, fingers are different sizes too, but maybe actually your fingers are similar to your body. So like, I'm small, so my fingers are small, but then you're also a small person, right? So there's some newer things about thinking about what your body surface area is, and that the vulva is probably like 1%. So if you think about it, it's again, how much are you covering? So a whole fingertip, like a whole thing, like from here to here, thinly, should be able to cover the entire vulva. But maybe you don't have disease out on the edges far away, and if you don't have to. The labia majora, those big lips, are not always affected, right? So I don't think it's very important to talk to the person who's looking at you and taking care of you of where exactly am I supposed to put mine? Because most people, it's central. Like, you really need it clitoris, labia minora, perineum, spot between vagina and anus, and then down to the top to bottom. And sometimes, like, how much you need to go laterally, like to the edges, depends on your disease. So, I think the half would probably cover if you're just in the middle, but you probably need a whole fingertip if you're doing the big lips too.
What about if it's maintenance?
And
you haven't got any symptoms?
It's the same amount, right? It's just twice a week. And again, sometimes, you're not putting, there's people who are like, I didn't know I was supposed to put it there. And that's common too. I think we give people a lot of information at the beginning. I do, and maybe not everybody does, but even when you get the information, you don't always intake it all right away. So going back over it, trying to remember, oh, am I missing a spot? Where do I need to go?
Yeah, because a lot of GPs in the UK will give steroids and just say to use for 2 weeks, and that's it. I don't even, do the guidelines which are set out by the British Association of Dermatologists, which is silly, but that happens. Also, it's mentioned as well that non-hair-bearing areas of the vulva, should you put cream there or not? Is it just where you have symptoms, that's where you put the steroid?
The non-hair-bearing areas are far more commonly affected by lichen sclerosus than the hair-bearing areas. The hair-bearing areas have lichen sclerosus, but they also have a lot of irritation. They're a common place for contact irritation, like from everything, sweat, urine, product. So steroids will calm down irritation there, but it's actually more the non-hair-bearing skin that is more affected by sclerosis for many people. So of course, so people think that it's inside, that by the lips apart. This is another thing I noticed. They think by moving the lips apart that they're going into the vagina. You can go in the vagina a little bit with the steroids. Don't worry about it, right? But you actually move those big lips apart and really get those middle pressures. Yeah.
Also, how can you tell you're in remission? Or more so, I suppose, how can you tell you're active? Because obviously a lot, unfortunately, don't get to see a specialist at all or regularly. So that's why I remember myself, I thought I was in remission. It wasn't until I saw my dermatologist that she said it was still active, because obviously you're a specialist, you can see more than we can. So is that just why it's best to keep to a maintenance dose?
I see this in the patient groups, and I don't see it in any of the specialty meetings I go to, this discussion. Like, we don't really, in the sense of, I think it's a debate about how do you actually know something's active without a biopsy? So in the sense that if you're symptomatic, if you're having the, symptoms, the itch burn, we know, okay, you're probably active. When we look, if we see a lot of, if we see the whitening, but also bruising, it looks like little purple flat patches. To me, that's always an undertreated person. It's a big red flag for me of be careful. But But the thing is, remember I said a lot of people have no symptoms. So they walk around with no symptoms and they can have major progression of their disease. So you can't really go by how you feel. And some people look and some people won't look. And it can be difficult for some people to look based on their, you know, flexibility, body habitus. So I think, you know, those are things we know you're active, but truly you could look okay. And if you're in a study, unless somebody biopsied you to see if there was inflammation there, there's actually no way to go without those things. Like, you know for sure with those things, but you could still be active without those things. And we don't really have anything yet from study perspective to say, you know, you look so good, go off, right? We don't have that. Now, the feeling at the moment, and things can change as people do new studies. Remember, nothing's set in stone forever. Maybe we'll have a trial that changes this. But at the moment, like 10 years ago, we didn't talk about maintenance all the time. There were fights about maintenance. Then there was a big paper that said, you know, maintenance twice a week really makes a difference. 90% of people do better with symptoms, way less progression, way less cancer. So now everybody should be on the twice a week maintenance based on that. But of course, it takes medicine time to catch up. And if you're not above the doctor, you're not paying attention to these studies, right? You learn what you learn, and then you tend to stay up to date on the things you like. So your doctors can't, it's hard for them to stay up to date on absolutely everything. So you guys, by all hanging out here, are empowering yourselves with knowledge to take back.
Yeah. We'll talk about the steroids as well. The dermatologists that I spoke to have always told me to throw the leaflet in the bin, because the leaflet that comes with the steroids aren't really for us for LS. And I think that's where a lot of the scare tactics from steroids come from, is reading the leaflets, especially those that obviously have eczema and use it large amounts over the body. They get, obviously, they say they're allergic to it and they get rebound. And I think that's what a lot of the other support groups use, really, to put people off steroids by saying this is going to happen to you. So if we could just go through really what's in the leaflet, where it obviously says the first one is not to use steroids on your genitals. So obviously we know that's not right.
I think that that's great, that that's what your people who prescribe are telling you, because I think that actually is I think that's a lesson for our side. And I do that too, right? Because we know as soon as people go to see the pharmacist or the chemist, you guys call, they're going to get these, you can't use it on the vulva. You can't use it for more than 2 weeks. It can't go inside at all. It can't be on a cut. And none of those things are true. Okay. We are to help you. We are not out to get you. One of my colleagues likes to say, you know, they don't look, the pharmacist or chemist is not looking at your vulva. We are, right? So, they do not know, and they're trying to help, but they're actually harming in this situation. Okay, we have lots of data, lots of experience, and you are not helping yourself in those situations. Like, again, because they're about everywhere on the body. Like, yes, if you're putting those, you don't want to put clobetasol on your face. Your face is thin, you know, the skin is thin. You don't want to put it there, but the vulva has fat, and it's different, and it's again, just listen to how you're supposed to use it. And then if your doctor should never be giving you high dose steroids and sending you away forever. That's not cool. They should always be seeing you again, at least once, to see how are you doing? Are we using too much? Are we using too little? What are we going to do now? How are we going to change it? Right? They don't have to, the specialists are not going to follow you forever, because they can't, because there's not enough of us in the world. But they should be able to help set you up so that the GP can follow.
Also, it says in the leaflet as well, which I've seen in the sport groups, people tell others not to do, is not to put on open sores. But again, that's what LS is.
Yeah, I actually find that yeah, it'll help your cuts heal faster if you put them on, assuming that the cuts are related to the lichen sclerosus and they're not, you know, something like herpes. But in general, they help the cuts heal faster. And if you're getting cuts from your lichen, it's usually because you're undertreated. And once the skin is stronger, and as the inflammation calms, your skin gets better. And as your skin gets stronger, it tends to tear less. And it's quite amazing. And people are happy. And so, but again, it is bit of a mindset change, right? Because it seems like the wrong idea. But
yeah, yeah. You know, it doesn't help because obviously the leaflet is saying all the things that we shouldn't do, which we are told to do for lichen sclerosus. Because even myself and Emma has even written to try and get the leaflet changed to add lichen sclerosus and to put that you can use it on genitals. It won't thin the vulvar skin if used correctly, but they said that until they update their, you know, that they update every so many years. So hopefully one day they will get that changed, because I know that makes it so hard for us in our group, because obviously other groups are quite anti-steroid, not all of them, but some of them are, and they use what's on the leaflet, and they use those that have obviously been allergic to it or used too much because they've got obviously used it for eczema and other reasons, and they use that to scare them into using it. And it does unfortunately work, because, you know, they just read the leaflet and it's saying all that. So hopefully one day we can get that changed, and that might make a difference and make things helpful, because obviously you've got people say that you can't just stop steroids straight away, you get rebound, you'll get allergic reaction, and like, you know, not just yourself, I've spoken to quite a lot of specialists, and they all say that they've been seeing patients for many years and they've never seen that in lichen sclerosus patients.
No, like you don't know. You can stop your topicals. I mean, if you're on every day, yes, you might have symptoms because they're controlling them, right?
Mm.
So
Yeah.
using the signs of using too much, again, rare, is if you're using everything, like if you're using too much and then all of a sudden you feel like you're starting to, you need more and more and more and more, and or it may start burning, that actually can be a sign that you're overdoing it, right? And it's so rare. So that's why I don't want too much time on it, because again, more underusers than overusers by far.
Yeah, definitely.
10%. Again, usually your clinician will tell you to back off, but that's a few times a year for me, you know, versus the 90% where I'm like, you need to put more on, please put more.
It is quite common as well when you first start in steroids for it to burn anyway, isn't it? Whereas a lot of people, it burns the first time, I'm not using that anymore. But that's quite common because you're putting it on, you know, new skin, aren't you?
Yeah, I guess it can. Again, creams are, like I said earlier, are more likely to burn if you're like thin skin, like you're menopausal, your skin is more sensitive. So if that's not being treated, you know, you can be more sensitive. A lot of the time things, you know, you got to try things more than once. But to allergy, I would say, you know, allergies to steroids, again, can happen, but are rare. So if you can put on your hand, like if you take a little bit and put on your hand and you're not reacting to it, you're not allergic to it. Okay, you can't be allergic on the vulva and not allergic on your hand. Okay, so I think sometimes our sister, you kind of like do a test and see what happens. Like, because again, you haven't been treated for, right? Like you haven't been treated, or this is new to you. What harm's going to happen if you put a little bit here and see? But maybe that'll make you feel like, oh, okay. I think you need to do that, but I think it will help if you're worried.
Yeah, because like you said before, there's a lot of different steroids to choose from. Not one will work for everybody. Some people can't use what we use in the UK is obviously Dermovate. You know, some can't use that because it is too strong. Rather than a potent steroid, they are given you know, a different strength steroid. And also as well is, do you use different strength steroids on different part of the vulva as well? Like for example, you said about having a figure of 8.
So I do. I don't know if everybody does, but I have found, although it's complicated, to if people have the perianal area is thinner, and I find sometimes people get into more trouble with stronger steroids there. So I will often have a much stronger steroid for the vulva, a much weaker steroid for the perianal area. And even though that's a bit complex, I find that can work better for people. So again, you say individualizing care, like making it for what that person has, what their symptoms are, what's holding them. I feel that a lot of people want to be the least amount possible, and that's fine. We want the least amount to control you, but you can't always tell yourself. Okay, you can feel how you.
Also, what about yeast infections? Can steroids cause yeast infections, or is it just a complication for having lichen sclerosus?
So yeast infections are very common in general in women, right? They're common. They are less common post-menopause unless you're on estrogen or diabetic or on some of the diabetic drugs can increase the chance of you getting a yeast infection. Some of the new drugs are actually, it's quite common. So these are things to know. So you can have a yeast infection and any of these things. So steroids, sometimes if you have an active infection that you may already have, can make it a little bit worse, but it would be very uncommon that people have recurrent yeast due to topical steroids. That I don't see that. Okay. You can get a yeast infection while you're on treatment, and then you treat the yeast infection, but it's very uncommon that would keep you from being able to use your steroids.
And also, what about the urethra as well? We mentioned, a lot of people seem to have more UTIs. Is that something that's just coincidence, or because you've got lichen sclerosus?
So UTIs are also very common post-menopause, because as your estrogen goes down, your skin is all thinner and more sensitive. So many people have urinary tract infections. So some of this may be an age group related thing. If you're menopausal and getting recurrent urinary tract infections, you need to be on vaginal estrogen, which may also help. Vaginal vulvar estrogen may help how your lichen sclerosus feels, but it may not be your lichen sclerosus. It's very few people that have obstruction, like blocking of their urethra where they pee from due to their lichen. Again, they've read about it and they think about it, but that's actually a very small group with usually they've have, relatively severe scarring, right? But most people, if we can see your urethra fine, it's probably not your lichen that's causing the bladder infections. So you need to look for other causes like menopause, like some people just are UTI.
The other thing as well is when you've got your steroids, some of them say to throw away after 3 months when open, some don't. They've obviously all got dates on. So what's the best to do with the dates and when you've opened a tube?
So our tubes, I'm in Canada, right? So our tubes if they come in a tube, they have a date on the end, like your toothpaste. So right at the end, there's actually a date that tells you how long the drug should be good for. And I do find it tends to be relatively accurate, because people who've kept them for years, it's like they're just using it as a moisturizer. Helping. If you're getting holes in your tube, like they crack over time, you probably should get a new tube. But I think those are, it's not necessarily like, how your makeup all says you have to throw it out after.
Yeah. I think a lot of the chemists will say too, because I want you to buy more. But I think it's the creams as well that say use within 3 months. But I have already contacted the British Association of Dermatologists, and they did say that as long as it's in date, it doesn't really matter how long you got it for. As long as it's kept in the right conditions, it'll be fine.
Yeah, and so it's harder. Again, I don't like, here we have a lot of generic as opposed to brand name, and sometimes the pharmacists or chemists put them into little jars for you because they have big stocks. I don't know if that happens in the UK, because if they've been there, then it's hard to know how old it is and how, so it's actually important if you're in a country, because we may have listeners here from other places where they put it into a jar for you, to have them put on like how long, they are expecting it to last, or what did it say on the big container.
Yeah, our tubes are normally given out in 30 grams and with dates on. And I normally say anyway, you should be using that, should take about between 3 and 6 months to use anyway.
It's interesting. So we don't have 30-gram tubes of much. We have 50. So again, these are country dependent of what the most common,
Yeah. Right, so that's that one. Also, talking about steroids, you've also done a survey, didn't you, to find out about why people don't want to use steroids. Tell us a bit about that.
So that's coming. We're trying to get that published. Somebody named Emily Del Perro, she's a gynecologist who spent a year with me and now is working in Ottawa. So yay, we have another vulva person in the world. So there's actually somebody who did their entire PhD in France about steroid fears and phobias, like a whole PhD, because this is super common, right? It's not just about lichen sclerosus, about everything, like, because steroids in dermatology, like that's their go-to drug. So they looked up, they sort of spent time interviewing hundreds and hundreds of people to find all the most common reasons people were scared of steroids. And so we asked them for permission to use it in lichen sclerosus, and they let us, which is really nice. And we did a study, and we have, I think, about 800 people answered. And the bottom line is, yep, people are scared for lichen sclerosus the same as they're scared for all the other conditions. And I think the bigger issue is that So, I mean, clinically, we know there's steroid fear. Like, I know, I know every day this is my battle in life, but I don't know what to do about it. Like, I think that's the next step. And if any of you have ideas, because I mean, I have lots of patients who are they're well controlled. I don't think, again, nobody likes to use a drug all the time. Like, you know, they like it, they like feeling better, but who likes chronic medication? Like, that's not normal. But if anyone can think of ways, because the happy people don't tell everybody.
Yeah, like, I think a lot of the problem is I think with social media now, it's probably getting worse for you than it is better, because obviously they can see more, and unfortunately a lot of people use it to their advantage, because obviously you've got doctors that want to use different treatments, you've got homeopaths, you've got nutritionists. We see it a lot on Instagram, that they use that fear of steroids and the false information to get you to go with their supplements, to do their things. I think it's probably going to get worse before it gets better, but it's mainly that it thins the skin, I think, and the allergic reaction are the two things that is in the leaflet, which was, again, if we can get the leaflet changed, I think that will make a start. So that's something that me and Emma are trying to get done. So hopefully if that happens, then we can get more people that will listen to their doctors where it says it doesn't thin. But even some GPs are saying to us in the UK, use sparingly, it thins the skin, because they're not obviously up to date on research and looking into steroids much, and they see it probably with those with, you know, that are using it for eczema, so they probably are giving that fear.
So I think you segue well to second line treatment. So because people are, so steroids, after steroids, okay, the other drugs that are used sometimes are called, they're immune modulating drugs like tacrolimus. Okay, so that is a drug that was invented for eczema. Okay, and it's here it's called Protopic, or it's called the thing to know, it does not of the skin. However, there have been 2 big trials comparing tacrolimus to topical steroids and lichen sclerosus, and they were inferior, meaning not as good as steroids. Okay, so yes, sometimes people find them helpful. I did a study on a survey of experts in the world and asked them what they use, and people only used it in the patients they couldn't control. So it's not usually an instead of. Sometimes it's if you're overdoing it with the steroids, it can help decrease the amount. But if people are giving it to you as primary treatment, like the first thing they do, they probably don't know this disease very well. Okay, it's not because they're doing something good for you, because it's not actually what the studies support doing. So it's second line, meaning not the first thing you do. Sometimes in addition, it doesn't have the same, we don't have any studies saying that it controls the symptoms or the progression or the cancer. And there's a bit of debate about whether it can induce, like cause HPV related cancers. So I would be very careful. It's not to say never to use it, but it is not in any guidelines as top therapy. It is not supported by the trials as first line therapy. So you need to know that. So again, sometimes it's helpful, but it's not the first thing. And then talking about you mentioned that there's a lot of preying on people to, you know, find a cure. So right, again, a lot of people hate this disease. They don't want to have it. They want it to just go away, right? So they look on Google, they look on the Facebook groups, they're trying to find a cure, and people will try to make money and they will try to sell you a cure. Okay, and remember that, like, they are preying on you as a way to make, and it's so sad. Okay, so things like PRP, the protein-rich plasma, and the lasers, right now, generally speaking, the studies are not very supportive of them. And the statements from the big international societies are not to use them unless you're going to be in a study. Okay? People promising you a cure are not being honest with you. And I have never seen anybody get better long-term. I've seen people go and spend thousands of dollars or pounds, and they may feel better for a little bit, and then they're back, and they don't look any better, and they don't stay better forever. Okay, so I know it's hard to hear it, because it would be nice, and maybe we will find new things, but the steroids are not as bad as they're made out to be for most people, and they really do help.
Yeah, I think that's the problem, that many don't give steroids a chance to work, because it can take time to find the right one, and put it in the correct place and the right amount, like you say. Again, they are trying to find a quick fix, and they are using some of these, I suppose, that are experimental with no long-term, results from it.
Even
and
that,
we see in the group.
if you
So
listen,
we did see in the group that some have used it, but it's only short term. It's made it look okay for a little while, but then you've got to do it again in a few months' time, and it's the money it's costing just for something to look okay on the outside for a little while, but not obviously long term.
and even that, it's what are they changing, right? Like, is it your symptoms? What are they promising you? Like, are they trying to bring your anatomy back? And again, like, what exactly? I was at a meeting where, a rep trying to sell these things, didn't know who I was. So they started telling me how, everybody's using this laser. Haven't you heard about it? It's all the experts know about it. I was like, who are your experts? How come I've never heard of them, right? Like, they had no idea that I know the world very well. And I thought, but they're telling all the people who don't know this. And they may believe it. And then they buy that laser, and now they have to pay for the laser. So how are they going to pay for the laser? By charging you guys to have those treatments. You'll see that most of those lasers, like the Mona Lisa, all these things, they're not in hospital-based clinics, because hospital-based clinics, in the world, because you have to justify the evidence for these things to get them into a public hospital system, and there isn't any.
So we talk about other treatments for lichen sclerosus. We've touched on estrogen cream. Can that help as well, even if you have got atrophy from menopause as well? But if you haven't,
I think the biggest data for it would be in menopause. Some people, if they are younger, if they're on birth control pills, some of the birth control pills can cause some skin thinning, certain ones. So if you're on birth control that's causing thinning, or you are low estrogen state from breastfeeding, or not getting periods because you have a hormonal IUD, like, those are all things where you may benefit from topical estrogen. But basically, people who are not on anything, getting regular is less likely to help. Moisturizers or emollients are the other key factor. So think about, you get dry skin. The idea of the emollient is that you're trying to seal moisture in. You're making your skin softer. So go from very thin to very thick. So thin things are like lotions, like they pour. Then you get your creams, and then you get your gels and ointments. And your ointments are those sticky, clear things, right? So I think that's a way to think about it. Again, if you don't know strength. So it's the ones that work the best are usually those ointment-based things. So I think you told me in the UK it was what was the brand again? That was
Hydromol, yeah.
Right, Hydromol. And in North America, it's Vaseline. Okay, so it's
no, we do use that as well in the UK quite a lot. I think more dermatologists now are recommending either coconut oil or Vaseline.
So Vaseline is very popular in North America. Some people are very anti-Vaseline, they just don't like the idea of it. So then we use things like, I looked this up last night. So here we use some Crisco shortening, sometimes vegetable shortening that you bake pies with. I think it's called Trex in the UK. Like, just some people think that's crazy, but people who don't want a drug, like, again, it's really easy. So the dermatologist I trained with used to say, put some in a jar, put it in your purse, pretend it's a fancy hand cream, carry it around, put it whenever you want. You can't do any harm with vegetables, right? Like, again, anything can irritate anybody, but it's less likely. Now, the coconut oil is popular right now. Everyone's putting it in their hair, putting on their body. Fine. It's a best picture every day. It works the best if you put on right after you bathe. Okay. But again, it can be a lot of money, but it should be some part of your daily routine. I would put it on after your steroid, and then moisturize, or moisturize some other time of day.
Yeah, we're running out of time, so just about that side of it. So just important to use something to wash with, as well as a barrier and moisturiser. And you say so it's got to leave it, is it about 20-30 minutes after you've applied steroid before you put anything else on?
I don't think that actually matters per se.
Yeah.
But that makes a difference. I think if you rub it in and put something on top of it, you're not going to it's not going to change the absorption. So
it's still important though to use moisturiser for those with LS to help hydrate the skin.
Super important.
Good, good, good. Right, so let's go through some of the questions because I've still got loads more, but we've nearly been an hour already. I said to you an hour would go fast, didn't I? We could talk about LS, but I could for hours. Can we touch quickly on biopsy? When to biopsy and what would the results be? Because obviously we get some people that are told they haven't got it, but could have.
Hi, this is tricky. Okay, so depending where you live, sometimes you need a biopsy because you can't get insurance coverage if you don't have a biopsy. Okay, so that's like totally different. If you have very clinically obvious disease, you don't necessarily have to have a biopsy, but again, as we've talked, not every clinician is comfortable diagnosing this disease. So if there's a question about what you have, like we're not sure, or you're not getting better with treatment, or we think there could be a cancer or a precancer there. If you have an ulcer, like a deep cut, if you have sort of pigmented, like some unusual lesions in there, like, things that look abnormal, those all need a biopsy. I would say a cut that won't heal, something sore and hard, because you can get cancer in 3 to 5% of cases. So if a clinician thinks a biopsy is a good idea, I think you should get your mind around it, and a biopsy is a good idea. If you've been using steroids, sometimes the biopsies are not quite accurate. I don't think they mess around with your cancer. Like if you have a cancer, I don't think steroids make a difference in telling us that there's a cancer or not. But the lichen sclerosus changes sometimes look a bit different under the microscope. So sometimes people will tell you to stop your steroids for a month before they biopsy you. I always do that because I live in a public system where wait lists are long, and if it looks really obvious to me, it doesn't matter. So when I'm biopsying, it's usually because you're either really questionable or really unwell. So I think again it depends, but there's that range of people always need a biopsy, and sometimes you need more than one. Like if I'm worried somebody has cancer and it comes back no cancer, and I look at it, it still looks bad, you need to rebiopsy them. Okay, because they're not always pathologists or doctors that look at tissue under microscope. Sometimes it's not like they need more. It's not perfect science. Like they can't always see both lichen sclerosus and cancer and precancer. So just when these things say you have it, you have it. When they say you don't have it, doesn't mean you don't have it. Okay?
Yeah, I think that's a lot. Quite often you can tell by looking, but not always.
No, but you cannot be classic lichen sclerosus, classic. Yeah. And a biopsy says chronic inflammation, we're not sure. And somebody will say to them, oh, you don't have lichen sclerosus. Yes, you do. Yes, you do. Where did your anatomy go? You have some scarring and inflammation, right? Because then some doctors stop treatment, and that's like the worst thing you could do for somebody. So, I think if you have a lot of scarring, or scarring at all, something's going on.
I think that as overall, most of the questions are supposed to get asked in support groups, and the anxiety side is LS turning to cancer. Like you said, it is quite rare. It's a rare cancer. Mine turned to cancer, but that's because I was untreated and undiagnosed for a long time. But what is it that someone should look out for if they have lichen sclerosus, for vulvar cancer, or even pre-cancer, Vin?
So my clinical experience goes with your personal experience, is that actually a lot of the cancers I diagnose, and probably I diagnose more than many people based on my practice, are people who did not have a diagnosis already, right? So they didn't know, and they were not treated. Okay, it's a very small group of people that I'm treating and watching that get a cancer. Okay, so number one. Okay, people with very quiet, mild disease that we control well, they don't really get cancer. Okay, there's people where they're like, no matter what we do, they keep getting worse and worse and worse. They scare me. Okay, so if you're that group, like you're really, we stay and we're doing everything, they're a tiny group. Okay, but that they just keep getting worse. That they're a little bit worrisome for cancer. But cuts that don't heal. Okay, you put your steroid on for a month, they're not getting better. Something like sore and hard, it's not going away. I've had one of my cancers told me before that patients with cancer that, like our drugs weren't working. So they just stopped instead of calling to come in, right? They just stopped everything because it just wasn't working. Well, but that was because it was a cancer had developed, right? So if you have suddenly like really bad symptoms that aren't getting better, you got to go in. You got to call and say, I'm doing all the things. Make sure you're doing all the things you're supposed to do, but I'm not getting better. If you start having bleeding from that, bleeding after menopause always needs to be looked at, but bleeding lesions on the skin, they need to be checked, right?
Yeah, it's important part to look, isn't it? Look regularly, take photos, like I've said before, so you can tell if it's getting better or not. That's the important thing. We've been going for an hour now. I hope they won't cut us off, but in case they do, hopefully you'll do this again with me another day, because we've not even touched on some of the questions we had, including the other vulvar conditions, obviously lichen planus, dermatitis, there's loads more. So hopefully we can do another one to include those in it, because like you say, they can coexist with each other, which is quite common in our group. We've got those with more than one condition. Of anything that we talked about today is obviously, if anyone can get the podcasts that you've started with the vulva diaries, most of these questions that you'll be asking today will be on there, because you speak to lots of different other doctors in their field. So get the podcast vulva diaries, have a look at that. They're in the group already. They're on my our website and on my link tree, because everything else that we've talked about is covered there as well.
Yeah.
If anyone's got any other questions that we never got a chance to ask or answer, maybe they can put on this when I put it on the grid, and if you get a chance, Dr. Selk, maybe you can answer some of them if they're not obviously personal advice, because it's just, there's so much to it. There's so many more questions I've got here we haven't got a chance to answer, so hopefully we'll be able to put more on it. There's more information on our website. We've also got obviously the issvd, you can get out information from the issvd, vulva Pain Society, our own website. There's loads of places where you can get help. Join our support group, because we do use obviously all other doctors tell us to do, and all the right ways of controlling lichen sclerosus and getting the right information, so that you can go with that to your doctor and talk about it. Is there anything you would like to tell anybody before we go?
No, I think this is great. I'm glad so many people were interested, and I think just to know, like, I just do this because I care. Like, I well, then I'm not sponsored. I'm not interested. Like, it's just one of those things that I do because I see so many people that are uncomfortable, unhelpful. But I do obstetrics, which pays me better to like, something to know, right? Like, the people who are doing true vulvar disease are doing it because they care. Many people in the world have long wait lists because, again, it doesn't get a lot of attention. It doesn't pay well, which is hard for patients because it's hard to get, and it takes time, right? Things that take time are hard. I did the Vulva Diaries podcast because my wait list is so long. I wanted other doctors to learn as much as possible about this. And it was just one of these like random projects I came up with for fun. Okay, so it wasn't aimed at patients, but a lot of patients have found it helpful. And there are a bunch of lichen sclerosus topics specifically, but there's lots of things. And again, as I said earlier, knowledge is power. Learning about yourself, learning about how you look and how you feel will help you to recognize differences. And the best way to get better is really to learn as much as you can.
Yeah, that's just it, is it? If in doubt, get checked out. That's what we say as well. But yeah, we just need to, obviously because of COVID, it's made all the waiting lists a lot longer, because in the UK, I know it's like it all around the world, but we used to wait 3 or 4 months if we got referred to a specialist. But now some are waiting up to a year and longer, and some doctors aren't even giving any steroids to help. They're just left. So support groups really are coming into their own to help with people in that way.
My clinic is out of control. It's like 18 months to 20 months, but again, I'm like a super subspecialist. I'm seeing all the people that derm and gynae both. Like, I'm a weird cross, right, between the two. So I'm seeing all the ones that people have already seen and don't know, and it's hard. But I'm glad you're doing this. I'm glad you're all interested, and I hope.
Yes, it has helped. Thank you very much, and I'll say thank you on behalf of all of us watching and the group. I will post this on the grid and also in the support groups. If there's any more questions added, maybe we can look at answering those. Sorry we didn't get to answer them all, but like I say, we could talk about LS all day, and hopefully you'll do it again with us another day and we'll get more done. But thank you all for watching, and thank you very much, Dr Amanda Selk. It's been fantastic. Thank you, everyone. Thank you, and goodbye.